So we have kind of thought a lot about the contributing factors for that, what are the root causes, and the sense of where women are able to access care, how they're able to access care has been a cause for concern for us, and we looked at it last year through a maternity care desert report. And this report showed that over 50% of all of the counties in the United States are essentially maternity care deserts, right? And it's not related to whether you're in an urban area or rural area. Most people intuitively think about rural areas as being most impacted by just not having access to an OB or having a hard time getting to an appointment to see a provider. But this also happens in urban areas. In Washington, D.C. in particular, we've been able to drill down the data and show that in one community, folks have had to take 3 buses to get to the hospital, which can take hours. So this sort of thing kind of begs the systems changes that we can make and allows us to think about the policy changes that we can make as well. So I do want to say a note about, our preconception health indicators and thinking about the strategies that we use to prevent or to improve maternal health are very similar to the strategies that we use to improve and to prevent preterm birth. And so we have data that kind of shows us what the chronic disease rates are for women, non-pregnant reproductive aged women. And we see here that I've highlighted the diabetes rates and the hypertension rates, and this is data from our behavioral risk factor surveillance system from 2013 and 15, which shows that we have high numbers of diabetes and hypertension, particularly higher in the Black community, which can contribute to, preeclampsia, gestational diabetes, and those things can kind of set you up for maternal complication, if not controlled, right? So all of that is sort of the backdrop for why we focus on health equity, what the data is showing us, and why we need to sort of stay vigilant in tracking that data and thinking through what strategies we can use to essentially ensure that we do have health for everybody, right? For good opportunity for health for everybody. And so what I want to do now is to just take some time to think through the social and the structural determinants, and we've heard a lot about this, but I think some of the nuances of this can help us to think through, what Kelly was mentioning earlier about violence and stress and how those things play out when you're in a community and you're trying to figure out what it takes to be well and stay well, right? So there are many, many determinants of health, and we kind of know through early research that health is a small part of health care, or a small part of health and disease is driven by actual access and delivery of health care, if you will. And so this chart shows you that, social, behavioral, and environmental factors account for about 60% of poor health and early death, right? So folks think that typically, if you have access to a doctor, if you're going to your appointments, if you're following the recommendations that your provider gives you, that you will have good health and you will have good health outcomes. You know that may not necessarily be the case because health is very much socially determined, and that's what this chart shows us. And even when we think about behavioral factors and the decisions that people make to smoke or not, to drink alcohol or not, those decisions are also very much driven by the policy systems and environmental conditions in a particular community, right? So what this does is it forces us to think broader than just healthcare, and to ensure that we're taking a very comprehensive look at health in general. So those social determinants are the context of our lives, the things and cultural ways that either determine or impact how healthy we are. And they're very much outside of the individual genetic endowment that we each have in the individual behaviors. So I think that physicians get this, right? They see patients, and if it were up to them, and this is research that comes from the Robert Wood Johnson Foundation survey that they did, if you ask, the physicians, this is a 2011 survey of primary care providers and family care physicians, they'll tell you they'd love to write out a prescription for safe, affordable housing, access to physical activity, fitness centers, greenways. They love to be able to write those things because they understand, that health is socially determined. But when asked if they really feel like they have any sort of control or responsibility or are able to impact those things, the percentages go way down, right? And that makes sense because their job is to focus on the clinical care, and we really need a better system to be able to impact the social needs of patients. So this data kind of underscores that point and provides another lens for us to really be able to think through those social determinants. Research also shows that those social determinants can help explain the inequities that we see, right? So this is research that comes from Dr. Jimmy Collins in Chicago, where he looked at those who had residents in a high-income neighborhood and kind of underscored the point that I made earlier, that African-American women living in a higher income neighborhood, even when you control for age, prenatal care, education, smoking, they still had higher rates of preterm birth. And we know that racial discrimination plays a part of this and contributes to higher rates of preterm birth and chronic disease. So these studies kind of demonstrate that when you think about discrimination being associated with low birth weight, discrimination being associated with a woman's risk for developing type 2 diabetes, which is related to pregnancy-related death, and chronic stress. Just the chronic stress of the lifelong minority status being a factor, an underlying social determinant of health in adverse birth and maternal health outcomes. So I just want to kind of pause here and make sure that I mention that even though these things are related to the social needs, that there is a higher sort of structural order to them, right? And we know that even if a patient has trouble accessing, maintaining safe, affordable housing, trouble accessing a higher income, employment, the right type of employment, to stay gainfully employed, and to be able to ensure that there is just a minimal threshold for being able to pay your bills and the like, that those things are socially, not just socially determined, but structurally determined. And they kind of go back to the historical legacy that continues to perpetuate itself in our country, where there were groups that had limited access to those systems, right? When you think about the legacy of Jim Crow, the legacy of segregation, the legacy of redlining, like these were policies that were put in place that limited the access and opportunity for certain groups to be able to achieve certain status and certain, access to just good health. When we think about it being socially determined. So I want to make sure that I mention that as we move towards solutions, all right? Black women in this community, and mostly in the Southeast it is, although we have high rates of poor birth outcomes, poor maternal health outcomes, I'm sure, among Native American communities. But what I'm highlighting here is sort of research that Black women have done, data that they've collected to ensure that there is some analysis of what their experiences are and how that can then give us some insight into what the potential solutions are. So there's a group out in Oakland, California called Black Women Birthing Justice, and they did a community-based research project where they essentially collected stories. They led focus groups with over 100 women, 100 Black women who had challenges in the maternity care system. And they asked them, what are your potential recommendations for solutions? And here's what they said. We want greater attention to birth plans. We want better communication among multiple healthcare providers. More careful listening is needed for patients during clinical encounters, and increased social support, right? Which, not far off the mark when you think about what you do day to day and the services that you provide and how this is your perspective. This is what we all want, essentially. The Black Mamas Matter Alliance is another group, and they may have been on our radar. They had a write-up in the People magazine recently with Black Maternal Health Week. They have a black paper that outlines some of the very same solutions when they have pulled information from Black women themselves and thought through what sort of policy recommendations they would want to see to ensure that we're actually addressing the needs of the women who are most impacted. So this is something for us to kind of keep in mind as we think through our perspectives, that if we're thinking about a solution, we have to go to the source and ensure that we're really pulling from those who are most impacted and not just hear them, but act on what they're saying, right? So there's that, and there's also major organizations, you know.
Won't be able to talk about all of it today. I'm just going to highlight a few parts, but I really encourage everyone to spend some time with it. There are really four main goals of this community health assessment. The first is really to summarize the health of the community of Mecklenburg County. The second is to talk about the factors and challenges that contribute to the community health outcomes, and then really identify what are some existing community assets and resources that we can mobilize to improve our health and community's health, and then to prioritize the top four health issues. The way that the community health assessment is done is there's actually about 4 or 5 aspects of it. The first 2 aspects include a review of secondary data, so whether that is state health data, CDC data, behavioral risk factor survey data, YRBS data that is already out there, that our epidemiology department reviews to start to identify some of the major trends and indicators. We also conduct a health opinion survey for community members, really trying to sample a broad range across the entire Mecklenburg County to identify some of these key goals that are listed up here. That two pieces of information are combined to then conduct what are called priority setting events, which are with key community stakeholders in public health and public health leaders across Mecklenburg County to really prioritize some of the top health issues. And the community health assessment, there are 9 health issues that are identified, and then those are prioritized in order based on these priority setting events. And then the 4 top health issues, there's an action plan that is determined for each one to talk about some of the efforts that we can do. On the years that the community health assessment does not occur, there is something that is issued every single year by the health department, again by our epidemiology department, that is called the State of the County Report. This is also available online. Again, the website is here, and I encourage everyone to look at it. What the State of the County Health Report does is really between the years that the community health assessment is issued, it again does a secondary data review, so looks at have there been any changes in the trends, have things continued, have things gotten better or worse, and summarize those around the indicators, and then provides an update, especially on the top 4 priority issues, the action plan that was developed, what has been done across that time. So I encourage everyone to take a look at all of those. So what I am going to do today is really just focus on a few of the indicators contained within these 2 reports that focus on maternal and child health, and specifically healthy pregnancy. What I will say is if you look at the community health assessment, the top 4 health issues that were identified are mental or behavioral health, access to care, chronic disease prevention, and violence prevention. Those 4 health indicators obviously relate in so many ways to preconception health, to maternal health, and to child health. But then so I won't talk about those specifically today, but again, I encourage everyone to go and look at the data in there. In the previous presentation, we talked a lot about preterm births. And as you can see in Mecklenburg County in 2017, 12% of births in the county were preterm, which is defined as prior to 37 weeks. This is still a number that is too high. Some of the health indicators that we talked about previously can impact this. We know that access to prenatal care is a big factor in this as well, and so I think that this is again just indicative of some of the bigger conversations that we need to have. And as you can see at the bottom of the slide, again, the data just indicates the significant health disparities that we see, particularly among African American infants compared to infants. Finally, I want to talk present the data about the infant mortality rate. I think it is important to look at this data and understand a few nuances related to it. In Mecklenburg County, there's somewhere between, usually I should say, between around 70 and 90 infant deaths a year. As we know, that number is just painfully high, and even 1 death is absolutely heartbreaking. But because of the numbers are not, when you have numbers of that magnitude, a small change in those numbers can change the rates pretty significantly. think that that's why you might see a significant decrease that might not be a significant number of deaths because you're starting with a smaller number. Interesting is that you did see between 2015 and 2016, we actually did see a significant increase, and that was largely an increase in deaths among African American infants. And I think that there's still a lot of research and data, or attention being paid to this data to really try and figure out why and how we can prevent that. Fortunately, in 2017, we did see a decrease. We will be able to look at the numbers from 2018 soon. I think it's still too early to really talk about trends. Right now, I think the bottom line is we know that these numbers, again, are still way too high, and we know that significant racial and ethnic disparities still persist, and that anything that we can do to affect this, we need to be doing. Birth control methods, all of the ones that are listed here. Nobody, I should say, is turned away from the family planning clinic because of inability to pay. We do accept insurance, we accept Medicaid, we accept B-Smart Medicaid, which is the family planning waiver for individuals that don't qualify, meet the income requirements for Medicaid. There's actually less restrictive requirements to get what's called B-Smart Medicaid that provides family planning coverage. But we also see a significant number of our population have no insurance, and we have a sliding scale based on income, and that scale does slide to zero. And so there are people that are seeing that do not have to pay anything. And we really strive to provide what is called patient-centered contraceptive counseling for women that do come in seeking contraception. What we have learned is we know that we do offer LARCs, long-acting reversal contraceptives, which we know when you don't take into account anything else are the most effective form of preventing pregnancy. However, on an individual level, we know that the most effective form of birth control is what works for the woman at that time. So it is not up to me to say this is what you should do. It is up to me to say, what is your pregnancy intention? If you are looking to prevent pregnancy, what is most important to you in your birth control, and how can I help you achieve that? But we really do strive to then talk about every single option, and then whatever option they choose, as much as possible, we try and provide it that day. Church. And then just very briefly, I do want to talk about our breast and cervical cancer control program. We know that breast and cervical health is very important, even when we're talking about preconception health. And so we provide free or low-cost breast and cervical cancer screening and follow-up to eligible women. I'll talk about eligibility on the next slide. So we do screening, and then for women that are diagnosed with breast or cervical cancer, at the time, if they have already been enrolled in this program, they are eligible for breast and cervical cancer Medicaid, which will provide funding for their treatment. And so we really seek to enroll women at the time of screening, so that then if they are diagnosed, they can receive the Medicaid. This is just quickly the qualifications for our breast and cervical cancer program. Again, it's based on household income level. It is a self-declared income. We do not need documentation of it. You need to not have Medicaid, Medicare, or other form of insurance, and then to not have been screened in the past year. And this is just some of the services that we provide through our breast and cervical cancer program. Then just very briefly, I wanted to talk about two other programs that are under our case management maternal child health division of the health department. The first is pregnancy case management, which is a statewide North Carolina program that really promotes healthy mothers and healthy babies, and it provides care management services for high-risk pregnant women. We refer any woman who walks into the health department and has a positive pregnancy test. This is an option for a referral that is made, but we also accept referrals from many different sources. And it really has two main goals. The first is to provide education to clients related to their pregnancy, and then case managers actually work very closely with pregnant women to, whether it's to attend their OB appointments or to do home visits, to really help empower them to have healthy pregnancies and try and address any barriers to that. And the services are provided throughout the entire pregnancy up until the infant is 2 months old.
And then looking at if that construct, if you're African American, or if you're Hispanic, or if you're another person of color, Asian or Indian, then you know what? You have multiple constructs that become barriers for you. And people need to know that the experience that they're having is real, right? And meeting a person there first, will often knock down some barriers. And then it's what you do beyond that place of understanding. But we also have to say to providers that we're a part of the construct. We are a part of the construct. The providers that they encounter, the educators that they encounter, we are a part of the construct. And if we operate within the construct without understanding, then we're going to affect people's ability to have new opportunities and to develop that future story. So it had to be provider education as well. And then building social capital. Okay, how many people have social media in the room? And how many people have followership? It sounds like I said follower worship, right? That might be right? That could be accurate. You have to be more careful. Okay, anyway. All right, so most people in this room how many people have the ability, if you apply for a job, or if you're thinking about moving to an area, that you can call someone up and ask them about it? How many people? Raise your hand. Look around. Most people in the room. All right? But if you are in a community where the only social capital you have are people that are just like you, that are not in any of the areas that you would want to break into, then how in the world can you change your situation? And then if it has been a part of your makeup that even the social capital that you have is managed in a particular way that is not most beneficial. So you might have social capital, but it's limited. And if no one ever teaches you about that limitations and gives you the opportunity to grow in your ability to network and manage the networks that you have, then where can you go? So we have to build social capital. And then painting future story. It's very, the word painting future story is specific because how does painting happen? How does painting happen? Movement, stroke by stroke, right? Future story does not just happen. It does not have future story. It has to be built stroke by stroke. So we help them to paint that. That led us to, as an overall project, so a lot that I'm speaking about, I'm talking about the experience with Mecklenburg County, and Union County, and our project, but it's not just specific to us. Remember, there are 4 other projects across the state, and they've been experiencing some of the same type of issues. And so from a state perspective, we said, wait. We've got to figure out, because we have a group of evaluators that work with us from UNC Chapel Hill, and we said, listen, we have to figure out if what we're doing is making an impact. We have to figure out if we're bringing people to the table, if it's making a difference, and if we're really capturing what's going to make an impact with the community, because we can't change without them. We can do all the changes in the healthcare systems that we want, but if we can't change people and their idea about the experience, then it's going to be a problem. So that brought us to the Health Equity Impact Assessment tool, and then implementing that in all of our projects. So the Health Equity Impact Assessment, which I'll refer to after this as the HEIA, the Health Equity Impact Assessment brings together, again, a wide group of people across the community, and it's important that those individuals, that it includes people as well as your impacted populations, you're going to bring them together and you're going to put 2 things together, all right? It's health equity. So we're looking at a health impact assessment, so looking at the data around what is happening with a particular area or a project or a policy or something that's being implemented, what is the actual impact, but then also racial impact statements. So looking at what has been the experience of the people who have thank you, who have been most affected or who will be affected by what you're implementing, and putting those together and packaging it so that you get an idea of if your outcomes will make a difference. So it is a preventative tool. It's structured for analysis, which is really important, and also unintentional consequences of what you might be implementing. And it helps you really evaluate so that you can improve service efficiency. So do I need to make changes, or is it working well? And it's certainly easier when it comes to actually implementing or making those changes. And then also a big part of it is just raising awareness on health equity because it's data-based. Some people come to the table and they had no idea that the situation is as it is. I mean, they really didn't realize. And so for them, being at the table kind of changes their entire outlook. The unique features are that it is it's inclusive, which is what I just talked about, bringing multiple people to the table. It's data-driven. So just like Dr. Sullivan took time to lay out the data and talk about how we built our services in Mecklenburg County, our clinical services around the areas of need, and make adjustments based on what we see with the data. This is the same thing. It is very intentional in providing a very broad data base, and then part of the HIA process includes narrowing the data and applying it to the program or policy to get the modifications that would make the most sense. And then it's collaborative across multiple disciplines. Data. So what you asked earlier about, so is this data, are these births in Mecklenburg County? Is it people who reside here or elsewhere? So that's one of the questions that came up. And then someone else asked about, so it's up to the age of 1, right? So we're not really just looking at birth out or pregnancy and the quality of the pregnancy, but there are other factors that may be included in the data. So our group really said the data has to be narrowed, and the data also has to be narrowed for what we call the impacted populations. So if you say that it's African Americans, like where's the data that really does a deep dive on what are the factors that contribute to that disparity ratio? And we didn't find it, or we haven't found it yet. And so we continue to work on that so that we can improve the data. And then the fifth step is just what we're doing now, which is evaluate and communicate. So we've made the modifications. We are evaluating through assessment, through survey for providers and for patient experience. We are evaluating through focus groups, and then we're communicating like we're doing today. We're sharing the message with as many people that we can, both in our county and across the state, that this is how we grow and this is how we make changes. And finally, did you get the picture? I'm sorry. There you go. All right. And then finally, the overarching goals of the HIA is to have policy leaders and advocates have the information they need to be contributors to the conversation, to have public health agencies active their programs are in building capacity within providers, and then community-based organizations they come in line and where they can be a part of collective impact, and then community and impacted populations having them feel informed and also having the ability to make adjustments within their communities. And we are now questions. Yes, ma'am.
I have a question about the postpartum newborn RN visit.
Yes.
Is that for all mothers or only high-risk mothers?
So I'm going to ask Lisa Salmons.
So that's a Medicaid reimbursement. It's a Medicaid reimbursement.
Okay. I know, but is it,
For
for the pregnancy case manager, they only see high-risk pregnancies? So, there's been,
This is a different program, and it does cover all.
Any woman that has
So pregnancy care management is Medicaid too. So all of what that was talking about is looking at Medicaid population. So we would now offer this to a Blue Cross Blue Shield client. But it is targeted to that population. So it's not all.
right, but I guess my question was, of moms who are Medicaid, some have normal pregnancies, some have high-risk pregnancies. So when they deliver,
There are some programs that visit all moms, so like Durham Connects, which has been adapted to the Family Connects, so that it can be implemented in other communities. So if you have an interest in that, look up Durham Connects or Family Connects School, and they provide visits to all mothers where there's funding.
Numbers stay the same. Any ideas? I heard our speaker this morning say that is not a rhetorical question. Any ideas? Access, silos, lack of awareness, possibly. Go ahead, Rita. Yes, so we have a lot of programs that are really focused on an individual. And when we look at the American Public Health Association, they tell us that public health promotes and protects the health of the people and the communities where they live, learn, work, and play. And while a doctor treats people who are sick, those of us working in public health try to prevent people from getting sick or injured in the first place, right? So that's our role as public health practitioners, is to focus on prevention. Now, I'm gonna bring up a situation that's not totally related to preconception health, but it is in certain sense. So let's talk about Flint, Michigan, right? There is a water crisis that has been going on for several years at this point. The public health messaging we hear, what are they telling people to do in Flint? Boil water. What else? Get bottled water. Is that gonna solve the issue in Flint? If you could fix Flint, how would you fix Flint? How do you fix this water crisis? They gotta fix the water. Who's responsible for the water? Are the citizens responsible for the water system?
No.
Not totally, right? Like, we should vote and put people in office who we feel like are gonna take care of things, but ultimately, it's not the citizens of Flint who are responsible for their water crisis. So, while there are some individual behaviors that can help to address the issue, it requires a much larger approach, right? And we have to think about that when we're talking about birth outcomes and health disparities and health equity, that we focus a lot on individual behaviors. If only mom would exercise, if only mom would eat healthy, if only mom would do X, Y, and Z. But are we talking about the community? If only my community would organize together and say we need a grocery store in our neighborhood. Or maybe my community needs to work on making sure that we have sidewalks. And I see my favorite crew. That's what I preach all the time. Lord, we need sidewalks that are consistent in Fayetteville. Can walk like 10 feet and there's no more sidewalks. But how does that impact a pregnant mom? Or a mom before she gets pregnant? If she would like to, instead of driving, in my situation, I live less than half a mile from my grocery store. I dare not walk there because I like living. And I like both of my legs, right? But there is probably a total of 20 feet of sidewalk, right? When I was in graduate school, I was able to live in Greenville for a little while, and I lived the same distance from the grocery store I walked every day. It was a wonderful experience just to get out, walk, take breaks, feel the sun and all of that, but you can't do that in my community. So when we talk about programs, sometimes we have to look beyond the individual and what can we do collectively as a community, and collectively as a state and a profession, okay? So here we move on to our activities. I told y'all we were going to talk about. So we have an exercise to do. So at your table, you have some data and you have some questions. And so what I'd like you to do is to work with the group at your table, identify a program that is related to the data topic at the sheet on your table. If there is no program that you all can think of as a group, you've got 10 minutes to make up a fantastic, okay? So answer those 4 questions and then select one person to report out. And you have about 10 minutes, so I'll give you until about 1:15-ish, and then we'll come back together. I don't have any fun music, so y'all just pretend like you're listening to your favorite.
know of that focuses on treatment or prevention of obesity for pregnant women? Is there one that focuses more on prevention? Eat Smart, Move More. Okay? Does Eat Smart, Move More address a root cause of obesity? Does it address a food desert, access to healthy foods? No? Okay. It's more of an educational program. So it's another program that focuses on me, the individual, right? Okay. Does it use a health equity approach? No? Okay. Is the community, or how is the community served a part of the development or the implementation of Eat Smart, Move More? Were they, do you know if they were involved in creating Eat Smart, Move More? They're in the pictures, right? That's all right, okay. We stood nice for pictures, okay? All right. Nice and focus group. Okay. All right. That's okay. All right. So what about moms who smoke? Who had that? Rebecca? Yes, ma'am. Stand up.
So moms that smoke, that's the one, the category we did. And the program that we identified is Triad Baby Love. Does it address the root issue? Yes, it does. And smoking cessation, we talked about educating the mom about how detrimental smoking is to not only her, but the secondhand smoke, to the baby, to herself. We educate them about quick line, no tobacco. And then number 2, does it address the root cause? No. Number three, our group said yes. Does it use a healthy, ethical approach? Yes, it does. And then number 4, with our program, we have a local action network where we get the information out not only to the consumer, but resources in the community and the other providers as well. So with the local action network, we look at it as from a policy making as well as letting the community know what resources are available for the participants and for the network in and of itself.
And your consumers are also involved in the
Yes.
policies, right?
Yes. They are.
I want to make sure you put that in.
All right, thank you. Thank you. You're welcome.
All right, so our mamas who have less than a high school education. Who had that one? Uh-oh, it's all right, stand up, be proud.
We did, does it focus on treatment or prevention? And basically, we decided that it's focused on prevention.
Which program is this?
It is called Safe Journey Program, here in Mecklenburg. Does it address the root cause? Yes, the root cause is, mothers dropping out, teens dropping out of school. Does it use a health equity approach? Yes, I think so. Because it's available on the focusing on targeting how has the community served part of the implementation? Like I said, it's available in the different communities where the need is infinite and community resources can also work. Thank you.
All right. All right, our below poverty group. Go for it, are you standing? You are?
Well, to be part of the group, so I guess.
She's by default our speaker.
By default.
It is a good one. She's a good one.
We chose to look at the WIC program. Does it focus on treatment or prevention? We
in a roundabout, we decided both. Treatment, because if there's some malnutrition or some just lack of food in the home, it treats that problem. Prevention, it prevents malnutrition, it prevents problems related to malnutrition in pregnancy, make sure they get the nutrition they need. Does it address the root cause? No. It serves them where they are, but it does, after pregnancy's over, it may take care of the child for a while, or the breastfeeding for a while, but then they go back to the same situation they were before. Does it use a health equity approach? Yes, because it serves the people that come to them. And how is the community served as part of the development or implementation? They're not at all. It's a federally funded program. It's been around forever. It's a good program, and it does change periodically, but the community does not have a part in it, implementation of it.
Thank you very much. All right, how about our uninsured group?
So we talked about the FQHC programs, and we dealt with the same, they focus on treatment and prevention, but do they address root causes? We said no, they do not address root causes. We said they would like to think they use a health equity approach, perhaps they do, we couldn't speak from it personally at this table, but the community is involved in the development and implementation because 51% of their board has to be community members, so they do have a voice to the development and implementation of
And our teen pregnancy. You go.
So, on our chart, the teen pregnancy rate has decreased, but we want it to,
It's, okay, we'll use, I'm sorry, there you go.
Okay. So, basically, we wanted to develop our own program, and we would call our program Mobile Teen Link Program. And we would go out in the community, because we realize there are two health departments and some other clinics that serve Medicaid patients, but we feel like there's definitely communities that are not served, and especially teens, they don't have their 15, they don't have their license yet. So we would have our mobile unit, would go out to where the needs are, such as Walmart, or hair salons, we would hang out there, and we would give education about how to prevent pregnancy. And before that, we would say like, hey, talk about what your life goal is, and what happens when you have unplanned pregnancy. And then we would, iPads. Oh, we would also have use iPads in that. So they basically would follow an algorithm, and if they clicked on what their life goals were, and are they in a relationship with one person, that would kind of help them find out what birth control method would be best for them, rather than us dictating like, you will take this. But it would be a decision based upon their lifestyle, what birth control methods would work best for them. It would utilize the health equity approach, because we're basically growing out, on the underserved areas for the people that don't have access to get to the clinics. And if they have any follow-up visits or need to keep coming back, they can be eligible for gift cards for things like get their nails done or get their hair done and things like that. And basically, we're serving the community, or they're definitely having some input because they're making it a shared decision about what birth control they should use. And we're definitely getting out there where the communities don't have access to the health departments or things.
And our last group, we'll talk about the babies.
All right, so we kind of took this approach on, things that are already being done and what we would like to see done. So we did the pregnancy care management program, to focus more on prevention to reduce the C-section and low birth weight. It doesn't have a root cause, so no, not really, but we would like to see healthy babies, healthy mommies. And so let's use a health equity approach. So it's for all mothers, so no matter their economic status or their socioeconomic status, we want to make sure this is offered to all mothers. How the community serves a part in the development and implementation. So we want to create a community coalition so we can have mothers and soon-to-be mothers be a part of this coalition, so we can get the word out and how to reduce each of these things here. Thank you.
That was fun, and I hope it helped to spark some thoughts, a thought process about being really intentional in the program development and implementation in your respective organizations. And also, you know, you yourself being an advocate as you are part of the group that's working to develop these programs.
Well, so I was asked just to close us out today with the call to action. I was told that whatever I say is the next year's theme.
No pressure there.
So here it is. Here's next year's theme. You know, so what are we going to do differently together to get different results with the framework of focusing on women, transforming healthcare delivery, and dismantling racism? Those are the things that we need to be doing. We need to do something different. You know, so I did hear a lot of things different today, and I think we've got the narrative that needs to be changed. There's been a lot of different things about, and we have guidance from Black Mamas Matter Alliance about setting the standard for holistic care and for Black women. You know, so we have guidelines, we have voices at the table. What we want to do is change the narrative so that when we talk about the data, we don't say that things like overall improvement but racial and ethnic disparities persist, that instead we say that we continue to accept racial inequalities, and what are we going to do to change that? To not accept the fact that it can't be changed, because it can, and we know there are models out there that actually have done it. They haven't been sustainable, but they've done it. And the reason why they haven't been so sustainable is the reasons why we have the inequality in the first place. So, and a key thing, again, is looking at data that is disaggregated. Constantly looking at data that's disaggregated. And one of the searing things in my mind is our map that really highlights states that are doing great overall. But the disparities are still bad in those states, and actually the worst in those states. That should tell us something. We've got to change the narrative about how we talk about these issues, make the invisible visible. We've got to do something different. What are you going to be doing differently? How are we going to be talking about this differently? Make that invisible visible. And come back in 1 year and say, okay, this is what we're doing differently, and these are the different results that we're getting. So that's what I have to say.
Here, pretty heavy charge for y'all. I'll see you in a year. But the charge is on. Thank you, Dr. Frank. Thank you, everyone, our panelists today, our presenters today, our staff, and every single one of you. Thank you for what you do every day in our communities in North Carolina.
Thank you.
Don't forget the evaluation, please. Very important.